Mayor Krieger weigh in, who was also our keynote presenter. Everybody is going crazy, wrapped up. A lot of these people at the APSS, the Affiliated Professional Sleep Societies meeting, which got moved to this weekend from June to be virtual. But we're going to jump right into it. We framed all the questions the same to all of the panelists across all 9 panels yesterday and today. Either in the framework of the panel discussion, which is related to this symposium track. We've got such a stellar track, and we're adding groundbreaking new presentations. For instance, you'll hear from Anuja from University of Indiana, who just had a meta-analysis come out with Macario Camacho on myofunctional therapy in pediatric sleep, just published in the journal Sleep Medicine a couple days ago. And so a lot of fantastic late-breaking presentations. So let's keep our answers tight and to the point. We're going to start with my co-chair, Dr. Denise DeWald, who is an honor to becoming a colleague of ours and a friend. So congratulations on your award for Rising Star Researcher at our gala. Thank you and welcome, Denise.
Thank you, Mark, and thank you, Samantha. So I started out in this field in myofunctional here. So some of the people who initially taught me are here, and I'm very grateful to be here. So as a sleep medicine doctor, what I see as the urgent problems in myofunctional therapy is to define what are causing these physical features that are associated with sleep apnea. So retrognathia, low hyoid bone, mouth breathing. What are the muscle patterns and the central pattern generators responsible for these? And figuring these out, it will provide us a pathway to be able to make therapeutic and preventative interventions against sleep apnea. And what we really need to do is do research with EMG and imaging. That's what I think we need to start establishing a data background of all of these things so we can start doing this.
I think that is just such an extraordinary topic. I know there are some of the leading sleep centers of research in the world who are looking to jump in on this topic and explore the relationship of myofunctional therapy to this video MRI. The technology is getting more and more accessible, and I think you're so right on. We need to phenotype the patients. We need to understand the actual mechanisms of each exercise. If we're going to grow up and be in the first tiers of medicine, this is essential. So thank you very much, Denise, and I look forward to working on this problem with you. Dr. Michael Gelb needs really no introduction, but he's a leader in dental sleep medicine, and he has been on this journey since the beginning of the AAMS. He was at our founding meeting, University of California, San Diego, a little over 8 years ago. Thank you, Dr. Gelb, for your contribution and presence here today.
Sure, it's great to be here, Mark. Thank you for the invite. I see this, the problem being general upper airway collapse and instability of the airway becoming increasingly more common. I think we're in an epidemic or a crisis of epic proportions, which is worsening every year, worsening in adults, children and adults. This is a problem that can start at birth and easily identified once trained to recognize, starting with suck, swallow, and breathing reflexes in infants, tongue tie, and progressing to airway-centered breathing disorders in teens and adults, creating a marked public health crisis involving mental health, cardiovascular health, and declining performance. We must be collaborative in our treatment approach. And I think what I'm looking for a solution is to, and for white papers, to redefine oral health. I'm really unsatisfied with the FDI definition of oral health. I'm starting to write my own definition. And I think, as Kevin Boyd pointed out, the 2030 definition could be better. I think fundamental is prevention. In prevention is identifying the epigenetic factors that involve chewing, diet, pollution, exercise, the environment. And the solution is points of intervention, ideally identifying at birth this risk as they do in Brazil, again at age 2 and 3. And then if missed, part of my idea and the solution would be a universal pre-K, which is 4-year-olds around the world before school, identify those with airway collapse, instability, poor tone, and work in conjunction with OT, SLP, pediatric dentist, ENT, maybe orthodontics, and use our schools around the world as community health centers. Whether you use guided growth appliances with myofunctional expansion devices, get at the root cause. And lastly, unite our schools with community health centers that we can start universally to be addressing these problems.
Mark. So
Mark, you have to unmute.
Thank you, Dr. Gelb. You've hit on some great points. Just to reference, the World Oral Health Forum has a little working group that has started. Michael Glick and David Williams, who are co-chairs of the think tank of the World Dental Federation, FDI, and we are working on updating that. Robert Lustig has jumped in on a little working group that I had a little role in, and we want to see that for the Horizon 2030 project. Thank you very much. Also, in terms of public health, we just got notice that we were asked to consider organizing a symposium, a late-breaking addition to the World Public Health Congress, which is the largest meeting. It's in October for public health in the world. And so stay tuned. I think we might have some exciting notices coming up this month. And I want to organize a special forum on this subject on a definition of oral health. So I'm working on putting that together for the month of September. Thank you very much.
Thank you.
For time's sake, I'd like to invite up Dr. Aditi Desai. Dr. Desai has become a friend in the last couple of years. We had some conversations about what is this thing, myofunctional therapy, and does it have any business coming into the United Kingdom? And so I'll let her talk. Thank you very much for your time and contribution, Dr. Desai.
Thank you, Mark. Thank you for inviting me to this. And of course, I must say I'm in total awe of everything that you've done so far. And I'm so overwhelmed with the number of high-profile speakers you have. And I'm sitting there thinking, why am I sitting on this panel? Anyway, so my experience in this field of myofunctional therapy is minimal. It's actually minuscule. But by virtue of my various positions as president of the Academy of Dental Sleep Medicine and Society of Dental Sleep Medicine, and my incoming presidency of the Royal Society of Medicine Dental Section, I feel that I needed to put a little bit more effort into this. So I met Mark, 2 years ago, Mark?
Yeah.
And at that point, he led me into this kicking and screaming. I kept thinking, no, this is not dental sleep medicine. This is ridiculous. No, I'm not going to do it. But I'm so glad you persisted, because he's converted me from a non-believer to a believer. And it's only taken me listening to a few of these speaker talks, and I'm just thinking, why have I not become more involved in the past? So I'm not a researcher. I'm actually a wet-fingered dentist, but I limit my practice to dental sleep medicine. So I feel that with what's been going on over the world, yes, we could have been meeting each other and learning a lot more, but I just feel that dental sleep medicine cannot be complete without the addition of this. It has to be part of it. And we know, like Michael Gelb just stated, that it's a global pandemic actually, and we have to address it. And I don't think that any one treatment modality actually helps at all. So what is the problem? It's a bigger problem than one imagines. And I don't think there's any one treatment for all these conditions that is sufficient. So this has to be a major part. And because it starts from birth, that has to be the major integral part of addressing a problem that may get worse, like Michael said. How do we go about it? Like, again, Dr. Gelb, you have stolen my thunder, but I'll say that oral health has to be redefined. I mean, you're talking to people, big prosthodontists, everyone wants distalizing, orthodontics, they're all distalizing, and they're looking at, sleep bruxism, thinking, oh, well, we'll just make them a splint. We have to stop all of that. We have to start from educating people, educating the undergraduates right from the beginning that this is how it has to be treated, and introducing sleep medicine, and all, growth, craniofacial growth, all of that into an undergraduate program would be the answer, I think. So thank you very much, Mark. I think this is all I have to say. Unfortunately, I feel a little bit of an outlier, a bit of a fraud, because like I said, I know very little about it, but I'm looking forward to learning more.
Thank you very much. I don't know if I'm jumping the gun to make announcements about the Royal Society of Medicine for next year. You could shake your head yes or no.
No, go ahead.
Okay, so we've been asked to, so we had a symposium last year with Dr. Desai and Adrian Williams and Joy Moeller and Samantha Weaver and Venkata Koka from Paris to really introduce the idea of myofunctional therapy to leaders in medicine and dentistry in the UK. And it was so exciting and wonderful experience. And I want to thank you, Dr. Desai, for your leadership. She's been elected as president of the odontological section of the Royal Society of Medicine. And so I think one of her first actions early next year, we're going to have a symposium virtually on myofunctional therapy that'll be pushed out to all of the Royal Society of Medicine. So we're very excited about that, and very excited about great things to come out of the United Kingdom. Our Congress Secretary, Katrina Rogers, is on our AAMS board, and will be heading up the first scientific society for myofunctional therapy in the UK. So thank you, Dr. Desai. Keeping with the theme of dentistry, we're going to jump to Dr. Kevin Boyd, who is a pediatric dentist and does a lot of orthodontics based in Chicago, and he'll be founding president in our opening ceremony. I hope everyone joins us today at 1300 hours Los Angeles, 2200 hours Paris for the founding of the International Pediatric Orthodontic Society. Go ahead, Dr. Boyd.
So Mark, I want to jump in here.
Oh, sure.
And I want to just say, so Kevin Boyd is my kid's dentist, and he is the one who brought me in here. And he's just a phenomenal person for us to all listen to, because he's really driving this research into how the changing skull has occurred over time.
Thank you, Denise. Dr. Boyd is the winner of our first Albert Schweitzer Award from the AAMS.
Can I share my screen?
Very quickly.
Yeah, it's 2 slides. You said I could do that. No? Change your mind? That's okay.
You can share your slides, yes. And we can also push them out.
Yep, you can. Yep, and you can like cut me off if you want. Patrick usually does that, but he's not here. Okay, so I got invited to do a commentary after I peer-reviewed an article on malocclusion as it might relate to risk for sleep apnea. And really, I praised the article a little and I criticized it, and they went ahead and published it. So anyone can read this, A Century of Adenotonsillectomy's Failure to Fully Resolve Sleep Disordered Breathing. You can read that. There's another way, adjunctively, not instead of. McNamara showed this a long time ago. You can widen the arch as young as 2.5 years old and bring the maxilla forward, and the posterior nasal spine comes forward. Guess what's connected to the posterior nasal spine? Huh? The soft palate. So here's another way to uncrowd the airway and maybe make TNA surgery more successful, more stable. So that's it. I'm done. How's that, Mark?
Beautiful. Thank you very much, Dr. Boyd. We're really excited about the white paper that we're working on reimagining the first 1,000 days of life, as well as another white paper on pediatric orthodontics and the necessity for intervention, really perhaps at birth or even in utero, so as it may be. So thank you very much. And next, I would just like to see, Robert, did you have something you wanted to add about sleep? Robert Lustig, who's going to be co-chairing track 8 a little bit later, right immediately after this. He's got some very interesting new connection of the dots on sleep medicine.
I wasn't planning on speaking here. I was just listening. But ultimately, this is not an obesity problem. OSA is not due to obesity. Everyone thinks it's because you get fat, your airway closes up, you get sick. And no doubt there are some people where that is the case, but we are seeing this in normal weight people, and we are seeing it in children way before they ever become obese. So this is a different problem, which hopefully Kevin and I and other people in Track 8 will talk about, how this
Freeze.
starts at birth.
Sorry.
And
Thank you very much, Dr. Lustig, for that great observation. I look forward to your panel immediately following this. So right now we're going to go to our AMS board member. I wanted to pull in Robert Lustig. He's a pediatric endocrinologist, and so much of this formation of the brain is so essential and critical. Our AMS board member, Dr. Silke Weber, is a pediatric otolaryngologist and sleep specialist from the state of Sao Paulo in Brazil. Thank you, Dr. Weber, for your work.
Hello. Well, first I want to congratulate everybody for this fantastic effort, for all this work what has been seen during this Congress. I think it opened the mind of a lot of people and showed that it is so important that we don't have to think just only at one point of disease, but we have to look at the person as a whole. So I think for us, the most important is I have to look not only as one obstructive point that I have to treat surgically or not. I have to look at the function, and I have to look after if this can be used to identify people at risk. So I do not see myofunctional evaluation only as a treatment, but I see it as a screening method. I see it as a method to help to phenotype OSA. So we have to learn a lot about it.
Thank you very much, Dr. Weber. Dr. Weber is involved in some committee work around the world at leading medical societies, including the European Respiratory Society. And I'm looking forward to her efforts in helping steer our white paper on sleep and myofunctional therapy.
And I want to,
as we're having a pediatric focus, I'd like to bring up a pediatric sleep specialist, Dr. Anuja Bandarpe. Anuja, congratulations on your article that just came out in Sleep Medicine. And thank you for your late-breaking contribution.
Thank you, Mark. Thank you for including me in this esteemed panel. I do have a bit of an imposter syndrome just seeing how accomplished all of you are. But I think what I want to bring to attention is, so I practice in the United States, and my functional therapy, at least in my part of the country, is still at a very nascent stage. So some of the time I do spend in trying to talk to the parents and trying to educate them on how valuable this is. So I think what the problem that I would like to focus on is on finding outcome measures of and how myofunctional therapy improves not just the AHI, which I feel most of the studies focus on, but also on the quality of life, because I feel like as a pediatrician and as talking to other parents, that's something which is very important to them. And I see a value of myofunctional therapy in not only helping improve sleep apnea and the AHI, but also in trying to see how it's going to affect their quality of life and how it's going to help with their behavior and other things which we know that treating sleep apnea helps with.
Thank you very much, Anuja. I'm really excited for you to join our International Research Consortium on Orofacial Myofunctional Therapy. We're building a network of children's hospitals really around the world, and we're looking at creating objective measurements and outcomes. So as we're moving on to pediatric, I want to bring up Dr. Umakanth Katwa. It's been great seeing him at meetings around the world. I think he really kind of jumped in. I organized a symposium at Stanford about 5 years ago on what we needed to do. And it was a strategy symposium, and he came in and he was just like so amazingly humble, you know, as one of the leaders in pediatric sleep at Boston Children's, saying, yep, we use the standard of care. Yep, it's completely broken. Yeah, we really need to look at this. So thank you very much, Umakanth. Umakanth, can you hear me? Dr. Katwa? I think he's having some technical difficulties. So moving along, I think we'll shift gears here and go to a little bit of an older population. Oh, Shannon Sullivan's joined. I'm going to ask you to unmute. And I know she's...
Good morning.
Good morning, Shannon. Your internet's out. I know you're calling in. So please, oh, there you are. Wow, look at that. Okay. Shannon is the recipient of our Rising Star Investigator Award, and we're really excited about her joining a research team that we're building. So thank you very much, Shannon, for being here today. I know you're very busy with the APSS. Shannon.
Yep, I'm here. I just turned off my video to try to improve my connection. It's a pleasure to be here this morning with you.
Go ahead. I think we've got a little bit of a technical difficulty. Shannon, are you speaking?
Yes. Mark, can you hear me now?
I can hear you now.
I'm just like the commercial. Great. I'm going to keep my video off, and hopefully that'll help with my connection a little bit. Sorry about that.
Shannon. Okay. Yeah. Umakanth, you have your sound working now? Okay, so we've got some technical difficulties. I'm going to shift gears here, and I'm going to move to a cluster of 4 different researchers that we have who are looking at adults. But before we do that, I'm going to go to a leader that we have in our myofunctional therapy, and it was a board member of ours, Dr. Esther Bianchini. She helped create the first National Sleep Society recognition of myofunctional therapy, which was done in Brazil. And she's a leader in myofunctional therapy. Thank you very much for being here today, Esther. Please unmute yourself. And 2 minutes here.
Okay, thank you so much, Mark, Muller, Samantha. And I'd like to thank the whole team of AAMS for allowing me to be here with you discussing sleep problems. So let's try to summarize something, because at this Congress, we could see all the conference that brought a lot of information, including about sleep and sleep disorders and our work. So what's the main problem? If you think that the last epidemiological study with meta-analysis showed that more than 1 billion people in the world have sleep disorders breathing, I mean, from mild to severe also, it really compromised their life quality and define a lot of comorbidities. So in 2018, something happened here in Brazil. Well, 2016, a very important thing happened in Brazil, and it was the accreditations and our work in Brazil. Orofacial myofunctional therapy is done by speech and language therapists. And in Brazil, the Brazilian Society of Sleep recognized it and our work, and we are all accredited. But in 2018, another very important thing happened here. The Brazilian Society of Cardiology in 2018 published an official guideline that is the first Brazilian positioning on the impact of sleep disorder on cardiovascular disease. of the Brazilian Society of Cardiology. In this document, the official myofunctional therapy that in Brazil is an SLP competence, but each word has different competencies. In this document, the OMT is defined as a new approach with scientific evidence. So it's paramount to invest in this field, achieving better diagnosis, as many of you said, and the eligibility criteria to each treatment. We are innovating. We are innovating in researches involving orofacial myofunctional therapy as a standard of care to these patients. But this therapy, as well as these professionals, have to be part of a team, a multidisciplinary team. So, what should we go into a related white paper? First, multidisciplinary team. Second, innovation. We are nowadays, we are currently betting on combined therapies to seek the best results for patients. We already have promising preliminary results for RMT and CPAP, RMT and intraoral appliances, weight loss and OMT. And I invite you to see my presentation and also to come to Brazil or nowadays to be in touch. Today, working together around the world means a few click on our computer or mobile.
Thank you very much, Esther.
I finished. Next World Sleep Congress is in Brazil. We will rock, but we are in Rio de Janeiro. But we will really make the difference depending on you, and you. So come with us. So join us.
Okay, so
Together.
the next World, as Esther said, the next World Sleep Congress, I'm so excited that we're holding it. We've been invited to host our 6th AAMS Congress in conjunction with World Sleep. We're so excited because there'll be thousands of people. People will just be starting to come out of COVID lockdown, start traveling. People are gonna have cabin fever, and it's going to be amazing. So we're gonna go very quickly now through a survey of some of the other Brazilian researchers who are here. There's a whole generation of people coming out with their PhDs in Brazilian universities, touching on myofunctional therapy. So I'm gonna welcome Camila Correa right now. Please say something for a minute or so.
Okay, thank you, Mark, by invitation. It's a pleasure to be here with you. Name is important in sleep disorders. And I would like to speak about the importance to myofunctional therapy in pediatric population. But continues with the speech of Silke Weber, I would like to add about the neurocognitive abilities, language, and my PhD was about this. We saw in OSA Pediatric the ability about phonological subsystem of language. It's different comparing children that know OSA. So, and the speech language pathology, it's more about the only myofunctional therapy. We have to do the diagnosis about the hearing disorders, the language disorders, dysphagia. So all of this depends about the good sleep. And in this population, pediatric population, it's be a difference in the future about the academic performance, about the growth and development, facial, and about this and our paper, our role is to end the public health. So we have articles about the dissemination information in this sleep behaviors, good sleep to behaviors and this population. How about the quality websites about the sleep? Its information's good or not to speak all population and to conscientize, Mark, I don't know, sorry, and to speak for more people who, how do you can sleep better and have a good life with these advices.
Thank you very much, Camila Correa. I recommend everyone see her presentation and look at her papers. As you can see, and you're going to see as we jump out of Brazil in a moment, there's such extraordinary research coming out. The top 4 scientific publishers, Elsevier, Wolters Kluwer, Taylor and Francis, and Springer, have all asked us to work with them to get a fast-track journal together. So there's going to be an explosion of research. And just to mention, everyone should go out and see our forum. You can see it on the AAMS YouTube page or the AAMS info Facebook page. We just recorded the sleep forum. We haven't even really pushed it out, and it's been seen by over 35,000 people last I looked on one metric. So a lot of exciting times, a lot of exciting information to come. So I'm very excited to welcome another Brazilian working on her PhD who has a great paper, Dr. Gabriele Ramos. Please come forward and say hello to everyone here.
Hello, everyone. My name is Gabriele. I'm a SOP here in Brazil, and I'm doing a PhD degree at the University of São Paulo, campus of Bauru, with the guidance of Dr. Giedre Berretin Felix. It's a pleasure to be here today, and I would like to thank Mark and Samantha again for inviting me. Many important works have been done here in Brazil on orofacial myofunctional therapy and OSA, and many others are coming. Research bringing greater scientific evidence on the effects of myofunctional therapy as a method of treatment to OSA, but also, as Camila said, expanding the view of the speech-language pathology to the other areas of our activity here in Brazil, and discussing how our work can be combined with other treatment methods. Personally, in addition, I believe that's important to develop research considering the elderly people and considering all the peculiarities in relation to the functions of swallowing, chewing, speaking, and the orofacial myofunction aspects in this population in general. Thank you.
Thank you very much. It's extraordinary to really think about, the luck we've had of great leadership in Brazil, and going back even to the 1980s, which has helped us with the great verticals that they've had due to their investment in research and the government and the universities' focus on the origin of problems, not just treating the symptoms. We really owe a great deal to Brazilian researchers. Thank you very much. Now, we're going to shift gears here because we talk a lot about public health and population when it comes to sleep medicine, because it is such an advanced disease state and carries with it gateways to diabetes, heart disease, cancer, really the big killers, obesity. And so when you look at 2 billion people with sleep disordered breathing, really, 1 billion with sleep apnea, another 1 billion with, sleep disordered breathing and snoring, it becomes, how do you wrap your head around this? And it becomes a little bit of a question, like, do we have a technology solution for this? So I want to welcome, we have 4 people, actually 3 doctors and 1 engineer who are going to speak in quick succession and weigh in on this topic. Thank you very much for your work, Dr. Harold Huberstrom, who has just organized a consortium in very short order with Horizon 2020 funds proposed, or is it locked in yet? So great consortium across leading Scandinavian universities. So thank you for being here from University of Oslo, Dr. Strom. Harold.
Thank you, Mark, and thank you for inviting me to speak here. I just want to share with you my first memory from a sleep congress, and that was in 2005 in Berlin at the WASM meeting, and I was listening to Dr. Gilmino, and he was showing a slide of a dog barking up a tree, and he said, are we all barking up the wrong tree here? And already then he was pointing at upper airway resistance syndrome, and I got interested in his work. So now when I'm an ENT consultant, I'm working to treat patients with sleep apnea, and I did my PhD on epidemiological research. But now the main focus is to treat these patients with sleep apnea. And I think the 2 points for the white paper needs to be, one, how to treat mild to moderate sleep apnea. And I think orofacial myofunctional therapy is a very good alternative as a monotherapy in motivated patients. And in these patients, I think that electronic solutions like we have proposed in the Horizon 2020 application, we don't know yet if it's going in. But I also seen the presentation of Carlos O'Connor, Ria, and Brian Crone, and it's a lot of technology coming up here for mild to moderate sleep apnea that we really should test in proper randomized controlled trials. And on the other side, we have this large group of almost 50% of CPAP users. And in these patients, they fail to use the CPAP, and I think orofacial myofunctional therapy will be a brilliant treatment to help people use their CPAP machines. And we also need more research on that. I haven't seen that many presentations. We have maybe one randomized controlled trial on that theme, but I'm very glad to hear that the Brazilians are coming up with more research here. So hopefully we'll be joining the Southern Americans and here in the Northern Europe. This is a complicated theme. And I think I end with a picture of another animal. We need to eat this elephant. It's a huge elephant. We need to eat it, but we have to eat it part by part with good research. Thank you and good luck. And thank you very much for a very good Congress, Mark.
Thank you very much, Harold. I had the privilege of speaking at his university in the local hospital and something special for the Norwegian Sleep Society earlier this year before lockdown. And our presentation there at the teaching hospital in Oslo, University of Oslo, wound up on the front page of, I think, the second largest or the largest newspaper. And it had the whole front page. Was it snorking?
Yeah.
So we have some exciting pressure building up amongst the general population. But thank you for your work and for joining our research consortium. Dr. Carlos O'Connor, he studied with our institute with his wife a few years ago in Estonia. It was great. And he immediately was like so excited and looking at how he could just start applying it right away. But thank you for your great presentation and some of your papers. Look forward to hearing what you have to say.
Thank you, Mark and Samantha, for inviting to me. This is a super meeting. I am really happy to stay with you. Well, really, we are talking about a problem about myofunctional therapy in sleep disorder breathing. I think that the main issue is to select the patient. We have to identify what is the real patient that can be treated with myofunctional therapy. So we have to make all our effort to try to look for the phenotype that is identified as hypotonic patient. This is the main issue. Once we select the patient, then we can try to try myofunctional therapy. But when we start myofunctional therapy, we have to be criticized that one of the main problems of this treatment, this therapy, is that the adherence. We have to be critical with ourselves that no more than 10% of the publication reach the date of adherence with this therapy. So when we start with this therapy, we have to assure that we have all the weapons to assure adherence with this patient when we start with this treatment. So we recommend when we have when one patient wants to start with this treatment, you are as practitioner have to assure that you have all the weapons to give to them. You can make sleep studies, you can make, in our case, IOPs, we can make DISE, that drug-induced sleep endoscopy, or MRI that has done a colleague for that. So we have to take that, to simplify, a phenotype, a patient that can be treated with nutritional therapy, and to give all the weapons to improve the adherence for this therapy. Thank you.
Thank you very much, Carlos. We're really excited about Spain. There's so many leading sleep research centers there, and there's a very friendly population looking at myofunctional therapy. You know, we've had some areas and pockets of it being adopted and even gaining some traction in universities there. So we're really excited about work coming out of there. I'm going to go back to the United States now. Dr. Umesh Goswami and Brian Crone have partnered together at University of Minnesota and in some other ventures. So Umesh, would you please be really quick? You guys are sharing a little slot here, okay?
Yeah, absolutely. Thank you for the opportunity to be part of this wonderful meeting and present some of our work and of course learn from everyone else's. So, you know, I think there's no doubt left that OMT is effective in treatment for sleep-related breathing disorders. And, you know, I'm an adult sleep medicine physician, so very excited that we have an option of offering something to our patients. The problem is that it is not still accepted as the first-line therapy. At least in some people, it should be offered as a first-line therapy for sleep apnea treatment. Most people right now just stumble upon it when they have tried CPAPs, tried mandibular devices, and have not been effective. Part of the reason it's not the first line is the current protocols of OMT for sleep apnea treatment are very complex. They involve a lot of muscle groups. We don't know which one are the most effective. So the solution that we have been working on, and I would like feedback from the group at later stages, is identifying the muscle groups that are most likely to be yielding good results in treatment of sleep-related breathing disorders when we exercise them. And, you know, building on to Carlos's comment, adherence is a big problem. So delivering the therapy through a digital mechanism, which improves compliance, and our approach of adding gamification to it, which brings people back so that they want to keep doing these exercises as opposed to considering them as a burden. And that's very exciting. And we're really looking for a simple, effective exercise that can be delivered to the people through gamification.
I'm really looking forward to that as well. And I know of at least 6 teams that are doing advanced work in that area. And we're excited to see what you guys come up with in Minnesota. And allow Brian to pop on for a moment. Just a quick comment. Brian?
Yeah, thank you, Mark. Just want to say hello, everyone. And yeah, Umesh and I are working on a lot of really interesting stuff. My focus is on adherence and how do we get people to do this in the real world through digital apps, and how do we bring myofunctional therapy to a much larger scale. And I'm really excited. There's lots of really good groups doing a lot of really interesting product work and research work. And I think the myofunctional therapy community is really bridging those two in a really exciting way that I don't think you're seeing in other places in medicine. So awesome work, everyone. Nice to chat.
Thank you very much. We're really excited. I mean, when we have so few people trained, and we're going to have a really interesting training and clinical competency announcement at our opening ceremony today, as well as educational. So stay tuned for our opening ceremony. But it becomes a technology problem. How do we scale up delivery of care? Because there's, to begin to scratch the surface of 2 billion people, how could we even explore that? Umakanth Katwa, if you want to come on, we have just like a minute or two left. So he's become a friend and erstwhile colleague. Thank you for your time here and contribution. He has a late-breaking presentation.
Thank you, Mark.
Coming soon.
Oh, thank you, Mark. Can you hear me?
Yes, we can hear you.
Okay, Mark. Thank you so much for having me. I know I'm actually on vacation and I'm trying to log in. There's a technical issue, but I think what I see the myofunction therapy is, the most important things from a sleep apnea standpoint, like form, function, and behavior, we pay less attention to the behavior of the airway. And moving forward, one of the clinical phenotyping which is missing in the sleep apnea world, particularly from a pediatric perspective, for that matter, is the myofunctional phenotype. Because that once you don't know, you don't screen them and don't treat them. And you don't treat them, you don't get benefit. And that's the reason you see with every possible treatment, there is no 100% benefit with that. So for me, 3 things I would like to see. I would like to see what are the norms. If the disease prevalence is so high, is it become a norm or is it an abnormality in the community? So we need to know the norms. We also need to know the epidemiological data from a different ethnic standpoint. We need to understand that needs. And the last thing which I want to say, which should be included in your white paper, is are there simple screening tool, like a physician's or a nurse practitioner or a medical student, or even for that matter, an NP can identify a phenotype so that once they can screen, they can provide the services for this patient. If you don't screen them, if it is not simple, not identified, nobody would even treat them.
Well, I don't know, Umakanth, if you remember, we were exploring all of these questions at the symposium you came out to at Stanford 5 years ago.
Yeah.
And I think we've made progress in every single one of them. And we have a long way to go, a lot of research to do. And I think our white paper will be a step in the right direction. Thank you very much.
Thanks,
I just want to invite back in my co-chair here, Denise. Do you have any last words?
I thought that these were like absolutely great suggestions, observations. I think phenotyping, these myofunctional phenotypes, is absolutely critical to be able to focus what exercises are going to be best suited for what patients and how we can best treat them. Because doing 20 to 30 minutes of exercises 3 times a day is not a sustainable thing. So we need to get it much down so it's something that people can manage on a daily basis, like brushing teeth.
Thank you so much, Denise. Thank you so much to our great panelists. Come into the Congress program. This is being live streamed around the world and available to the public, so people will be able to get a little taste of what you guys have to offer. And hopefully they read your research papers and they come see you lecture when we start going to congresses again, and they join the AAMS Congress. So we'll see everyone at the top of the hour. We're going to take a break now, and we will return with track 8, which will be really exciting. Nutrition, chewing, and systemic health. You don't want to miss this. There's some groundbreaking discussion that's going to come up. Thank you very much to everyone. I love you guys. And I'm so excited to be getting the show on the road, as we say.
Thanks, everyone.